is that the structure tonight is that we're going to have six panelists share a little bit about their history and what motivated them to get into the field, what they spend their time doing. We're going to have about 7 minutes for each one. So I'm going to introduce each one in turn. So we're going to start with Andy, I see, Andy Craig.
Hi, everyone. My name is Andy Craig. I am an associate professor of behavior analysis studies, neuroscience and physiology, and pediatrics at SUNY Upstate Medical University. I direct research for the Gallo Sano Center for Special Needs, and I am chair of the behavior analysis studies training program that we have here at Upstate. My path into applied behavior analysis, which is the specialty that I'm representing this evening, was kind of nonlinear. I am a laboratory scientist by training. I was an undergraduate and fell in love with laboratory research on psychology, specifically behavior analytic research that focused on the behavior of non-human animals. So I did a lot of research with rats and pigeons and mice, asking questions about impulsive decision making and addiction and persistence and resilience. And I love, don't get me wrong, I love basic laboratory sciences, but there is such a strong interface between those sorts of questions and questions that are relevant to human health. So after I graduated with my PhD from Utah State University back in, I won't provide the date, so I won't date myself here. I pursued postdoctoral training to sort of see where the rubber hit the road, and the rest has been history, so to speak. I was interested in better understanding how I could use all the cool stuff that I had learned about in the laboratory to help people. So I worked at the University of Nebraska Medical Center for about a year, but coming to better understand the procedures that we use to assess and treat behaviors of concern in children. And when I say behaviors of concern, I'm talking more specifically about challenging behaviors like aggression, property destruction, self-injury, disruptive behavior that we may see in populations of individuals with intellectual and developmental disabilities, pediatric feeding disorders, what have you. So I wanted to better understand how I could use my laboratory sciences to help in these settings. Um, so I spent about a year intensively studying these sorts of treatments, which ultimately led me to upstate New York, because there was an exciting opportunity at Upstate to help spearhead an undergraduate internship opportunity at Upstate and a graduate training program to really help fill out the workforce of frontline workers who are passionate about providing these services to individuals in need as well. But there was also a need to develop research programs, which is something that I'm also very, very passionate about. So, as an applied behavior analyst, I spend a lot of my time working with children, which is super rewarding. I love working with any sort of population, but children are they have a particularly close, I have a close connection with them and they have a particularly large spot in my heart. Um, so once I started working with children and seeing the changes in their lives and the change in the family structure that we could produce using the principles of psychology, I was hooked and never looked back. Um, so I spend a good portion of my day helping to direct clinical programs that focus on helping people, right? So those might be helping children acquire academic skills or social skills that will help them to integrate better their into their class cohorts, or reducing behaviors of concern, equipping children with assisted daily living skills, helping families function better. And in addition to those clinical undertakings, I also do quite a bit of research, not only to better understand how to more efficiently and effectively deliver the treatments that we arrange for children, but also to remove or to reduce barriers to treatment, to address concerns that we have here in central New York and throughout the state of New York about accessibility to treatment. Downstate, we have a lot of wonderful treatment options for children who are in need and families who are in need. But here in central New York, we have Syracuse, Albany, Buffalo, everything else is kind of the wild, wild west. So a big part of what we do, a big part of our mission at Upstate is to equip practitioners with the skill sets that's necessary to get out there and to continue to help people and to make the treatments that we arrange um, more accessible to these families who are in need and sometimes who are in crisis. Um, so yeah, I'm excited to share my experiences with all of you.
Okay, terrific. Thank you so much, Andy. I have questions for you, but I'm gonna I'm gonna hold back so that we can move on to our second clinician. So our next person is Suzanne Haas Cunningham, who's going to talk about her work in marriage and family therapy.
Hello, everyone. I am, is it coming through okay? Yeah. I am a marriage and family therapist, and that does not necessarily mean that I don't see individuals, but my training is in marriage and family therapy. And if I go back to why I first started in this particular field, it's because my interest, I started out being a teacher, but my interest just overwhelmingly was always into how kids were getting along and how they were in their families and the relationships involved. And so that sort of morphed into a career in marriage and family therapy. I currently have a full-time private practice. I have history teaching probably for 7 or 8 years at Syracuse University in the marriage and family therapy department. I also worked for quite a few years in an eating disorder clinic, being the family therapist there. Prior to that, a big interest of mine was medical family therapy, and I ran a program in a doctor's office. Those would be my particular areas of interest prior to now. Now I just have this very wide-ranging practice in my private practice that is in my home, and I see probably half people online and half people here. I would say that the other thing that without a doubt brings me to this field is that I am the fourth of 5 children in my family of origin. So I also happen to have a bed that had the head-board above the stairwell in the house that I grew up in. So I heard all the stuff that was going on, and I feel like I've been a family therapist since I was very, very young, and always interested in how everyone was getting along and what was happening. And as like many people who go into this field, you end up being that person in your friend group who is interested in finding out how people are doing and how they're getting along and so forth. I wanted to pick a couple of particular things. One is that you'll compare and contrast therapy fields with individual versus relational work, and I would say that relational work looks most at the dynamic between people as opposed to the dynamic within people. And for me, that's really interesting and fascinating, and it's also very hopeful. So the symptoms are more in relation that we're looking at are more relational as opposed to being more individual. And when you've seen an individual and then you see them with their family members, it just is so enlightening. So I always feel kind of sorry for people who don't include the family members in their treatment because you just see so much once you see everybody together. It's like, oh, I get it now. So that's so important to me and my practice, I would say. And then I would also say in a world right now where people are more and more passively interacting and more interacting in ways that are online and through the phone and through social media, we really need marriage and family therapists on the front lines to help people learn how to relate better, to help people learn how to focus on conflict and be able to work things through. I find that young people today have a hard time meeting with their family members and also their peers to directly talk about issues that are happening in their lives. And so I'm really very, very pro marriage and family therapy and relational work right now. And then the last thing I would say is I can't imagine a more interesting career. I mean, I really don't need to watch the movies at all that are on media. I have plenty of drama in my life, and in terms of my own personal growth, you really can't do this without growing personally and doing your own work in your own relationships and on your own self. So expect to be, strapped in and be really confronted with the things that are your own issues and other people's issues. And it's just a wonderful, wonderful career, I would say. I have never been bored. Like I said, you can go from different aspects of marriage and family therapy. Like at one point, I was really into medical family therapy. At another point, I was into teaching. At another point, I was into eating disorders and families. And now I just see the gamut. And the maybe the cool thing is the older I get, the more I know I don't know everything. And so it's just such a beautiful thing to have people that you see teach you all kinds of things about life. It's just, I'm so thankful. So that's it for me.
All right, thank you so much, Suzanne. Okay, so next up is Daniel Miller.
Hey, I'm Daniel. I'm an assistant professor of mental health counseling at SUNY Oswego. So I'm representing the mental health counseling profession. And our profession overlaps in a lot of ways to some of the other professions here, marriage and family therapy, social work. A lot of the places I've worked, all three of us kind of work together in tandem. I got into the field originally. I actually didn't do a psychology undergrad. I was a animal behavior and music double major, and that was a hard thing to reconcile. And I did an internship at a zoo, thinking I wanted to be a zookeeper since I was 6, and hated it, and had a quarter life crisis, and went to my college counseling center and saw a counselor, and then sort of realized, hey, maybe I could be good at this. A lot of the aspects that interested me in animal behavior and taking care of animals and things are things that can extend to people as well, and understanding how people tick. So I decided to get my master's in mental health counseling. There's so many different professions you can pick to do therapy, to do counseling. I picked mental health counseling, partially because my therapist who I saw who helped me through that quarter life crisis was a mental health counselor, and partially because mental health counseling is unique in that we really focus on wellness. That's really our focus. So although we do diagnose and we do all of that, our focus is really on helping people understand kind of their whole life. So their work, their relationships, their sort of intrapersonal world, who they are on the inside, all of those different things, and how all those things sort of work together. And so that's really what defines us amongst the professions. Another reason why I went into mental health counseling is I didn't think I wanted to do a doctorate at the time, even though I ended up doing that anyway. And I could practice with a master's degree doing mental health counseling. So that's a perk if you don't want to go all the way through a doctorate. And I'm trying to think. So yeah, mental health counselors, we work with in all different kinds of settings. We work with individuals, couples, groups, all kinds of different things. My experience primarily has been in college mental health. So I've worked in 3 or 4 different college mental health clinics, counseling centers. And that's where most of my experience lies. And what's great about college mental health is that you see the gamut, sort of what Suzanne was saying. You see everyone coming in with anything in crisis, struggling with depression, anxiety, eating disorders, personality disorders, all kinds of different things. Just relationship issues, roommate issues, academic issues, career issues. It runs the gamut. And so that's where most of my experience has been. But mental health counselors, we work in college mental health centers, but we also work in agencies, hospitals. School-based mental health counseling is becoming more and more common. So working in the schools with kids and sort of being embedded in a school. So we work in eating disorder treatment centers, addiction centers. We kind of, wherever there's mental health, we're probably there. So mental health services. So yeah, so I love working in the field. I'm a professor of mental health counseling now, but I also have a very small virtual private practice. And I work with individuals in my virtual private practice. I love it. I work primarily with like the queer community, and helping with identity concerns and things like that. So that's me. I'm trying to think if I left anything out. I don't think so. I'm excited to talk to you guys about mental health counseling. So
Okay, terrific. You all are doing so well with time. I'm basically useless here. But okay, so next up is Adriana Molina. Did I say that correctly?
Yes, you
Was
said
it?
it correctly. Yep.
Okay.
Hi, so I'm Adriana. I am a licensed master social worker, and currently I work in an elementary school right in Utica. So those of you that are from Utica College, I work for the Utica City School District. So my path to social work was unexpected, to say the least. For undergrad, I went to St. John Fisher and I double majored in psychology and communications. I chose psychology because it was interesting, but really I was leaning more toward communications, journalism, and marketing, actually. So my internships in undergrad were all marketing related. I did the school newscast, and so I graduated undergrad really thinking I was going to work for a news agency. So my first job out of college, I didn't go right to grad school, to be honest with you. I didn't really know about social work until I was in probably my mid 20s. So I worked in a news station. I got in with advertising and I hated it. It was not for me. So after that, I ended up getting a job in case management. So I was an outreach specialist. So it kind of meshed being able the communications and outreach, kind of like marketing piece, but getting people involved within the Medicaid population that had mental health issues or chronic conditions. Linking them to doctors, linking them to mental health providers. And so I really found that that's what I like. I enjoyed doing that. From there, I met somebody who kind of introduced me to the idea of social work. And they were like, hey, you'd be a great social worker. And I was like, well, I don't know what that is. So I did my research and I learned more about it. And they talked about, the therapy piece and, being able to work with children or adults with mental health challenges. And it really sounded like it was for me. So I went to UAlbany for grad school while I was working full time in care management. And from there, the way that they did it there was you tell them the populations that you work with and they give you an internship that is the opposite. So I'd only worked with adults at that time, and they gave me an internship that was with children, and I was petrified. But I found after my first internship, I fell in love with it. I love working with kids. I love, you have the opportunity to be silly, but also help them in a way that's impactful. I love the resiliency of it. And so my first job as a school social worker was New York Mills. So for those of you that know, it's a very small district. So it was K through 12, about 40 kids per grade level. And then I was offered an opportunity at Utica City School District, which is awesome because I went to Utica schools and I'm actually working in the elementary school that I went to. So that was kind of like my full circle moment. And I've been there for a couple years now. Again, I really enjoy, we do a lot of like social emotional push-ins for the kids. I do a lot of individual school-based counseling. Because we're a bigger district, we have a lot of kind of like Daniel was mentioning, like embedded, we have a therapist that's embedded that comes to our building. We have some care management individuals that come there as well. So it's really great for us to be able to work with one another to support the children and work with their parents as well. So even though, again, my path to school social work was unexpected, I'm very happy with where I'm at. And I look forward to answering any questions that you guys have.
Okay, great. Thank you. I'm starting to think that a good question, maybe once everyone's had a chance to introduce themselves, would be for people who've worked with kids to talk about what's distinctive about working with kids versus adults, since we have kind of a good mixture of representation on that here. Okay, so next up is Lauren Warren Farrisee.
I'm Lauren Warren Garrissey. I am a clinical neuropsychologist at SUNY Upstate. And I was a psychology and German double major, so I knew I wanted to do something with psychology because I didn't think German would be particularly useful unless I wanted to go live in Europe. So I looked for jobs after I graduated college and ended up with a 3-hour interview doing as a research assistant in an Alzheimer's research unit in Connecticut, and just absolutely had no idea about the field of neuropsychology, but really enjoyed sort of the puzzle aspect of it and the brain aspect of it and the people aspect of it. So for folks who aren't familiar with neuropsychology, it's sort of this intersection of neurology and psychology. So I did that for 3 years and kind of learned about a bunch of different tests that I could give. So we, gave tests to these patients to see if they qualified for clinical trials, and then they took medications, and we retested them over and over. And then I decided to go to graduate school. So if you want to be a neuropsychologist, you have to go and get a Ph.D. in clinical neuropsychology, which I did at UNC Chapel Hill, go Tar Heels. And then you have to do an internship and a 2-year fellowship. So I did both of those at Duke, which we don't talk about because go Tar Heels. So after I finished with that and my fellowship, I was faculty for a couple of years at Washington State, and then ended up coming here to upstate New York, where I've been a full-time clinician for about 11 years now, and I love it. So you can certainly, if you want to go into neuropsychology, you can certainly do research. You can work with children. You can work with adults. For me, I am the opposite end of the spectrum. I absolutely love working with older adults in particular. But you can I basically assess patients with a variety of different cognitive disorders. So patients with epilepsy, multiple sclerosis, Alzheimer's disease, and all the other various dementias, Parkinson's disease. So I administer all these standardized tests, administer them in a standardized way. I interpret them and the test findings. Sometimes I integrate it with all the clinical information that I get during an interview, and write up a very long, shorter now report that can help patients understand how their brain is functioning, if there's a certain diagnosis that explains why they've been having, memory loss or language changes or what have you. I try to convey that information in a helpful way to both the patient, the family, as well as the medical professional that referred them to me. And we talk about it. So I do a feedback session to explain my findings. And that's sort of the basis of what I do. I spend a lot of time with patients, which I love. So my appointments with them are 3 to 4 hours long. So I really like that aspect, that I get to sort of really get to know someone in sort of a short period of time. I have to know all about their background and where they went to school and how they did, and use that information in conjunction with the test findings that I'm getting. And I also really love being part of a team. So I get to communicate with a lot of different medical professionals, with geriatrics, with neurology, with primary care. And that's sort of what I do. There's a couple other things that I do. So I also lead a cancer and cognition group. Tomorrow I'm going to be talking to a group of folks who have HIV and talk about like normal aging and aging with HIV and like some strategies to compensate for cognitive issues that they might be having. So I like to do a lot of like education and promoting brain health. I supervise students and interns and teach residents about neuropsychology. So I think that is, in a nutshell, what I do.
All right, thank you. So our last panelist is Michael Webb, who has been teaching at Colgate. He's going to be sharing about forensic psychology.
Awesome. Thank you. I'm going to go ahead and apologize in advance if you hear any loud cat meows or a rogue limb going under the door. I have a cat that's very upset that I've locked her out. So if you hear that, I apologize. I'm Michael Webb. I'm kind of representing the overlap between the legal system and psychology. So a bit of a different kind of history as far as what other people have talked about. as far as my trajectory, I kind of was thinking about this. For me, it kind of goes all the way back to high school. It's kind of something, a really good experience when I was in high school with a psychology class. I was like, man, this, I feel like you look at plants or chemicals or rocks, things like that, they don't change, but people are very dynamic, and that was super interesting to me. So I went to school, got a degree in psychology and criminal justice. So I had some interest there. I eventually went to a Ph.D. clinical psychology program that was what's called a generalist program, which I was very grateful to kind of have that experience. What that means is the opportunities that were available for me as far as like training extended to working with children, which I learned for me did not like very much, working with couples, working in outpatient community centers, with students, all kinds of work, and forensic work as well. At the time, when I was in school, my plan at the time was to go into academia. I'm very interested in research, enjoyed kind of the statistical modeling side of things more than most people do. But I really fell in love with forensic work. So I had an opportunity to work in a maximum security prison, doing violence risk evaluations. So what that looked like was sitting down next to someone who had been convicted of a violent offense, interviewing them, taking time to understand their risk and using different kinds of measures, things like that. And then forming an opinion using that information from what we know from research, as well as kind of some clinical judgment as well. And then using that to taking those reports and informing parole, release decisions, placements in prisons, things like that. So that kind of really stuck with me. And when I went into kind of my internship and future career, that's something I wanted to get more experience on. So since then, I've had opportunities to work in prisons doing more treatment side of things. So I would consider what I was doing in school to be more assessment based. So I was working to understand personality in folks and using various actuarial measures, things like that. As I went into internship, I was able to do kind of what I would call like three pillars of clinical work. So I was a psychologist in a prison and a civil confinement center where I was doing individual therapy with people that had been convicted of violent offenses and sexual offenses. A lot of group therapy, which was also a really interesting, very different experience, kind of more moving parts in that kind of environment, and assessment. So looking at personality structure, cognitive assessments, things like this to get an understanding of how people are functioning and how to help better interface them with treatment. I did that for a while and really loved that work. But I've actually recently moved to a new position within the Office of Mental Health, as a psychiatric examiner, which is more assessment based again. So what I do in this position, I similarly interview people. So I'll sit down. Now mostly it's mostly virtual when I'm interviewing someone, but I review cases for Article 10 of mental hygiene law, which allows the state of New York to confine individuals convicted of a sex offense past their sentence if they're deemed to be dangerous enough to be released to the community. So part of that process, it's a really significant and kind of serious thing to take away, that piece from someone. So there's a really extensive legal process that folks go through. Part of that is the report I would write about that person, assessing their dangerousness. So kind of going back to the same ideas of using actuarial measures, understanding personality, especially as it relates to personality disorders. And for me, like a research interest that has also become a clinical interest and assessment interest is psychopathy. So that's something I'm frequently kind of speaking to and looking for and working to understand, both in a treatment setting and in a assessment setting, and using that information to come up with objective reports to kind of explain where someone's at as far as their dynamic risk and their ability to ultimately, ideally, kind of moderate that risk to where they are safe to return to the community. But that is part of the process of kind of what I'm looking for. Do a couple other things too. I have the opportunity to teach at Colgate, which I love, once a semester. I have a small private practice as well where I'm able to kind of continue to do some of the individual, more outpatient work with folks. And I think like kind of think about what I like about my career, and I really don't know what I would do if I weren't doing this. I really love this kind of work, and I can't imagine what I would do otherwise. There's a lot of variety and variability in the stuff you can do. Probably as people see all the stuff that folks that have similar degrees are doing even just today. So able to do that. I also I think took with me in my program kind of a love for research that I've been able to still sprinkle in and do some research with the state of New York as far as recidivism data and treatment outcome data. So I'm still able to have my hands in kind of different research pots too. So I really like the variability and all the different things you can do kind of going down this career path. So I have no clue how long this has been, but I think this is probably a reasonable time to wrap up. But look forward to any questions too. So thank you.
All right, that was perfect. Okay, thank you all. That was really such a good introduction to the incredible variety of pathways that we have represented here. I think Dr. Pollack is going to take over from here. But maybe if it's okay, I could pose my question just because I think this would be of great interest to students. Um, that you are all working with a range of ages, and so we've got the full spectrum from earlier childhood up through old age. And I think it would be helpful for students to hear a little bit about like what attracts you and what do you think are kind of distinctive features of the population, that age population that you have tended to be working with. I think it's good for students to have a sense of what's different about working with kids, for example, versus college students versus, couples versus older adults. And there's no order to this. From here on, it's kind of a little bit of a free for all, I guess.
I'd be happy to share my
Yeah,
experiences.
go ahead.
Working with children, I think the phrase that comes to mind most often is that no 2 days are the same. So the first of all, there are so many behavioral dynamics that are sort of unfolding on a day-to-day basis where you might start working with a child early in an assessment protocol, and their behavior at the beginning of that protocol in the same day might be very different from the way that they're behaving at the end of that protocol, right? Children get antsy. Sometimes it is difficult to maintain attention to the different things that you're trying to work on with them. So I think being able to think on your feet and having a passion for working in those sorts of environments can be really helpful when you're working with children. Not to say that working with adults, you don't necessarily need to think on your feet quite as much, but my kids keep me busy.
Actually, rather than a free for all, because I like a little structure, maybe Adriana, since you also are working with kids, it would be great to have you chime in.
Yes, so I would agree. I think for me, what I love the most is just there's a lot of things that happen that are unexpected. I think it's also a personality too. Like I'm a very goofy person, and I think that kind of works well with kids because if you're doing an activity with a kid and you have it very structured, if they are not into it, they're not going to do it, and they don't care. So it's really just about adapting to that and just kind of going with the flow. Sometimes I'll have like, for example, today I was working with a kid that has ADHD, and I had a really structured activity. We were going to kind of work on this book on what to do when he's angry or he gets frustrated. He was not into that. So we got up, we had to do like a body break, a movement break, and I just completely changed the activity that I was doing. So it's that part of it. I think the difference in working, because I did work with adults in the past, is that the connection piece. So for the little ones, a lot of times they don't necessarily know how to express this emotion. So if they're feeling frustrated, they're launching a chair across the room. Like they don't know how to verbalize and explain, like, this is what I am feeling and this is what I need. So you are really taking it down to the basic level. This is what this emotion feels like in my body. When my heart starts to go fast, then that means I'm feeling a little bit frustrated. And here's what I do to prevent that, to prevent me from losing my cool. Another thing within the school system too is, you're working with the child, but you're bringing in the teachers, you're bringing in the parents, you're bringing in everybody around because we all want to be able to work together to help this child in the best way that we possibly can. Versus, when I've done therapy with just adults, it's like, hey, this is what we're working on. Like, here's your, homework. Do that versus kids need a little bit more guidance and they have a lot more support around them, depending on, who's a part of their life to kind of help them along that way. So I think there's a lot of moving parts and pieces. Another thing I kind of notice is that sometimes we have to give kids more credit for them being able to say what they need, or sometimes, maybe they're not using the right words, but they can express to you what they're feeling and what they need. And sometimes as adults, we feel like we know what they need. And we feel like we have, we're trying to guide them in the right way when we have to kind of just take a step back and let them have a little bit of leeway to kind of lead and then make our decisions and supporting them and helping them find their voice as they get older. That was a lot in one, sorry.
No, that was perfect. Thank you. And actually, I would just echo my own background is in working with kids, that if you work with kids, you also work with adults, because kids tend to bring a whole bunch of adults along with them, whether it's their parents or the school system, or all kinds of groups. And so I think that's part of what is special about working with kids, is that there are cases with adults where you're working with the whole system, but I think it's more likely to happen when you're working with kids. Anyone else want to chime in on kids or adolescents? So maybe moving up to adults. I mean, Daniel, you were mentioning that you've worked with college students.
Yeah.
Could you say something about that?
Yeah, I can talk about that. So yeah, I worked mostly with college students in my private practices, mostly young adults. And what I love about the young adult kind of phase of development is that there's so many questions about identity, like who am I? Who am I going to be? Um, Also, I think, you guys are probably, a lot of you are in this developmental stage. Well, that's why you're here. What do I want to do, with my degree? So there's a lot of questions about who I am, who I want to be now that I've left the nest. Who am I really? What did I take from my family, and what do I want to keep, and what do I want to grow and change? Um, I also really love about that time that there's a lot of big questions, and maybe more existential questions that clients might be asking, related to, like, not only who do I want to be, but also, like, what happened to me? Like I just got through childhood and adolescence, and I just left the nest for the first time, and I may be living on my own, or I just started my first career or bought my first house or whatever it might be. And I'm dealing with all of these issues in my relationships, or at work, or within myself, and kind of knowing who I am or how I want to express myself, and really exploring, like, where did this all come from, and how did I get here? And I just think those are all really fascinating questions to explore with clients. And so, yeah, that's why I really love the sort of young adult phase.
Okay, any of the other more adult focused folks? I mean, Suzanne, you're working really with a mixture, but
I am really working with a mixture, yeah. And I would say that right now, there's been other times in my life where I've seen kids individually, but I wouldn't do that right now. I would only see kids with their parents and or family members. It didn't have to be both, but I would pretty much do that family therapy. So it's probably my focus would be relational with the child involved right from the beginning with kids.
Mhm. Right. Any of the adult folks want to add anything? What attracts you, and why do you love
I'll jump in. I love working with older adults. I think one of the things I love about it is they're these fully formed people. So you really get to hear people's history, their life story. I think as a society, we sort of don't think as much about, maybe because we haven't gotten there yet. But so generally, they're very appreciative of the time that you're spending with them. I feel like there's a lot of wisdom. I'm a little bit different because I'm not doing therapy with them, but I'm doing these assessments. But of course, I'm a psychologist as well. So there is a lot of, like, helping them adjust, doing sort of therapeutic feedback. Like, what does it mean that you have these cognitive issues, and how can we help you adjust and help your family adjust to these issues. So yeah, so I really enjoy that piece of it, sort of that they have this whole story already, and there's a lot of wisdom and gratitude there. So
Okay, thanks. Okay,
I
Deb,
guess
did someone want to?
I was just going to weigh in real quick because I
Yeah.
work with a pretty unique population, I guess, for a lot of what I do. As far as like people who are incarcerated or kind of in the interfacing with the justice system, I think for me, like just kind of the way I'm built, a lot of the enjoyment I get from what I do is kind of figuring out how things worked and how people are put together and understanding like what's called often case conceptualization or kind of construing what's going on for a person, whether it's what escalates their risk or what kind of cognitive deficits they might have that's making that where they're not able to understand treatment the way other people might. I think that part's really interesting. The other part, as far as how I'm built, is like I think um, challenging things are really rewarding for me. So that the population of incarcerated folks are understandably pretty not happy about a lot of the situations they're in. And I think that makes it really challenging. It also makes it super rewarding for me, at least. So I think like that piece is a lot of what I get enjoyment from, and kind of using that to I'm also mostly working in an assessment kind of environment, so I'm not doing direct care with folks as much as I used to. But there are ways where those assessments can be written in a really empathetic way kind of serves as a vehicle for the treatment providers they might work with that are going to say, hey, this person really has these vulnerable areas that we can target, or whether it's highlighting those things in an assessment where it's breaking down their cognitive functioning or how their personality is structured. So I think it all kind of comes full circle, but the challenging and rewarding kind of ratio is, I think, a big piece of why I enjoy the forensic work.
Okay, thanks.
All right, I think I'm taking over now.
Yeah.
Thank again, everyone, so much. I love hearing about the variety of all these different settings. I think it's so wonderful for our students to hear. So speaking of our students, students, please put your questions in the chat. And we already have one from Grace. So I will start reading the questions. And again, whoever wants to, lead off with answering one of those questions, and we can have more than one panelist answer. Not everyone has to answer. But the first question is, what best helped you decide what specialty was the best fit for you?
Uh,
After you.
Okay, I would say trial and error. It was working with a bunch of different populations and just feeling what clicked the most. I had a very different experience when I worked with kids. I was like, no, that's just certainly not not what I want to do. I love kids, but not in a therapeutic setting for me. So yeah, I would just say trying a bunch of different things out and then seeing what feels right and what you sort of connect with the most.
I second that, Dan. When I was an undergrad, I floated from lab to lab to lab, trying as many different specialties within psychology as I could, given that those opportunities were afforded to me at the time. Behavior analysis just sort of clicked because it was data-based and it helped me to. I'm a data-oriented individual, so it helped me to have the opportunity to quantify behavioral outcomes that I could graph and then watch over time as they unfolded in a longitudinal manner. But in terms of the specific population that I ended up working with as an applied behavior analyst, we do a lot of different kinds of things in applied behavior analysis. It's a big, broad field where you can work in IO psychology, children, geriatric populations. There are so many different opportunities within applied behavior analysis. But I've always had a passion for working with kids. So the fact that I was able to sort of get the chocolate and the peanut butter, so to speak, two different passions of mine coming together to produce an opportunity that was greater than the sum of the parts, was absolutely how I ended up where I am right now.
Yeah, I think I also, as a neuropsychologist, I like my data and I like the puzzle piece of it. So that was, and again, I kind of fell into it. I tried a couple different things, but like Michael was saying, I love that there's, I mean, I love the brain. I think the brain is fascinating. There's always new stuff that I'm learning about, which I really like. There's always patients coming in with like disorders that I know nothing about, and I have to frantically Google and figure it out and then figure out, how their brain is working together. So I love that piece of it. And yeah, man, I wish I loved working with kids, but I there's like adults that go with the kids, and that just wasn't I don't know. I like working with older, I mean, they have difficult children. The older adults I work with, they have difficult children, but they're adult children, so I can handle that. Um, yeah, I don't know. I like that end of the spectrum. So you got to figure out what works for you, I think.
I would say if you listen to the stories that everybody's told here, that there's things that happen, you kind of go forward and you feel your way, and then something clicks, and you go in that direction, and then something else maybe pulls you, like it's sometimes it's pretty random. Like, I know that's not comforting for somebody who's younger, but I think about, I had acquired a best friend in grad school. I was in a different program, and she was in marriage and family therapy. And one day I was at her place and I just sat there and looked at her books. And I was like, wow, these are so much more interesting than the books I'm reading, like. And then I happened to have a research professor who was from the marriage and family therapy department. And all of the research that she quoted was all the stuff from marriage and family therapy. And that was it. I was sold. Like, that it was like random things that like pointed me in the direction. And while I was teaching at the time, I was so interested in what the kids were feeling and how they were getting along, not so much in the lesson planning. So like for me, like as time went on, things started focus narrowing down, and it sounds like that's true for a lot of people here. Like, you might have started here, but then you ended up over here because things pulled you there. And it's very cool actually to hear all these people and how each person is so excited about what they're doing. It makes me feel really good about the field in general. Like, it's very exciting that, sometimes we think that people are just a pain in the ass. And here we have all these people that enjoy working with people. We're saying, yeah, this is good stuff. So I feel good about this.
I think for me too, it's, to be honest with you, I think what helped me realize that I was in the right place was, and it probably sounds a little bit cheesy, was like I didn't get the Sunday scaries anymore. Like, I didn't feel like I looked forward to going to work, and I hadn't had that feeling before. So it really does come down to figuring out what drives that passion in you. I think that's how you should feel when you can find that. Go off of that. When you're looking forward to being where you're working, that's huge. Not everybody finds that. So I definitely say that's how I know.
I'll also echo what everyone's saying. The trial by error piece is definitely helpful. If I could go back in time and tell myself anything when I started grad school, it's that you're not really signing your acceptance in blood, and they're not going to hold you to going into a career in academia or working with children and things like that. So I was, at least from my experience, I was really grateful to be able to try a bunch of different things. My experience with children did not click for me. I think the last time I was working with children, that we were doing a mindfulness exercise, they said no and threw a Hershey's Kiss at me, and that was enough for me. Yeah, I'm good. It didn't work for me. But I think like doing that forensic work for me was my research interest was in self-regulation deficits and self-regulation failure. It just felt like this extension of like being the bridge between the scientist practitioner, that I know this research, I'm familiar with it, now I can actually see it kind of in person, which I thought was really cool.
Thank you, everyone. Just to echo what everyone says, because I think students get really nervous that, they have to know what their career path is going to be, like, where they're going to be 20 years from now or 30 years from now. I think, just to echo what everybody's saying, often you only kind of really can focus on, okay, what am I doing next year? Or what am I, next year, the next between, 2 to 3 years. And there's steps, right? You take a step and you do a thing, and then you learn something as you're in like that situation. You learn more. I had the very similar experience to others here, where I thought I was going to be a child psychologist and kind of was thinking that path. And then through graduate school and experiences on internship, similar to what Michael and Lauren, I think, were talking about, I was like, oh, no, never mind. The kids are fun, but the grown-up people that come with them, that's a whole other challenge. So yeah, like, and then, I pivoted and things come across your path, like Suzanne is saying. So yeah, don't kind of feel like you have to have, the next 20 years planned out because that's just not how it works. But there's a lot of other great questions here. So the next one is from my student, Elizabeth. So this is going to be for Dr. Warren Pharisee. I would love to hear more about the different paths in neuropsychology related to cognitive disorders. And also, I was going to tag on to that because I wanted to ask you, Lauren, I can't remember if in New York, are there psychometrists or neuropsych techs? And so
Yeah.
maybe that would be a pathway also you could tell the students about.
Yeah, that's a great way to get into neuropsych is you need to have a bachelor's degree in order to administer the test. So there's a type of position called a psychometrist where you're basically just learning to administer the test and administering them to various medical patients. So you would work with a neuropsychologist to do that. And that's a really great way to get experience. It's a great way to figure out if you even like working with, these types of populations, if you want to work with kids or adults, and you get a bunch of experience in terms of the various tests. There's also a lot of research labs where people are doing research projects where there's a cognitive piece to it. And so that can also be another way to sort of get entree into some of that data. But I think there's also a lot of people who have more of a neuroscience, sort of a more hard sciencey background that end up kind of shifting, want more of a person focus. They start out with animals. So I have a colleague who started out working with rats and now sees people. So, but definitely getting experience kind of with the testing with psychometrists is a great start. And feel free to email me later if you wanted to chat more about neuropsych specifically.
And then also, we don't really have anyone here represented from this field, but if anybody knows about it or has experience with it, what about folks who work, for example, like with the Office of People with Developmental Disabilities? I know they have psychologists and other mental health counselors that work, for example, in group home settings with adults that have cognitive deficits or developmental disabilities. And I think sometimes you can work there with a bachelor's degree, master's degree, doctorate degree. I think they have different levels. That's my understanding. I don't know if anybody here has experience with that or wants to speak on that because that's another career pathway as well. Okay, so let's move on to the next question. Let's see. From Daniel, for those who pursued a doctorate degree after finishing their master's program, what motivated you to make that decision, and how did your career opportunities or scope of practice change?
I can speak to that. I think, like I said in my intro, I originally didn't think I wanted to do a doctoral program. I had my quarter life crisis and was like, okay, I gotta quickly pick up a psych minor and then I can make it to a counseling program and then I can practice. But then I think what I found was, especially for me not having a strong psych background, like I said, I just had a psych minor by the time I graduated. When I left my counseling program, which was 2 years, it's a 2 to 3 year master's program, depending on how many courses you want to take at once. But I just felt like I hadn't learned enough yet. Like I felt like there was more still that I wanted to know, and I also was it appealed to me to do to teaching and be a professor. And I was really interested in clinical supervision and things like that. So I decided to go right into a doc program so that I could do that. I actually found that speaking of the Sunday scaries, the first time I didn't have the Sunday scaries actually was when I became a professor. I loved doing clinical work, but I'm also quite sensitive. And so sometimes I would get overwhelmed with the volume of clinical work I had to do. So I decided that teaching might be a better venue for me, and it was. And so, yeah, once I got my doctorate, and if you're in the counseling profession, your doctorate is typically in counseling and counselor education. Then I was able to teach, and I love training counselors and helping them develop. And so, yeah, that opened that field. So if you get a doctorate in my field, you can do clinical practice, but you can also be a clinical supervisor, so supervise other clinicians. You can be a professor professor. You can also do research, qualitative and quantitative research. So it opens up a whole lot more avenues, I would say.
All right. Anybody else want to speak to the master's to doctorate? We can kind of move on to some other questions. Great. So this is from Nick. This is a great question. How do you separate your personal lives and keep yourself separate from your work so that it doesn't impact you emotionally?
Nick, that is such a good question. Um, and just I know that everyone is going to have a slightly different perspective on this and answer it in a slightly different way. But for me, the answer is you don't. And I'm like I hate saying that, right? Because we like to believe that we're able to compartmentalize and our work stays at work, our home stays at home. But often as psychologists or any human facing healthcare profession. You're working with individuals who may be in crisis. You're working with individuals who may be in situations that are very, very challenging for them. And as someone who's really passionate about working with and helping people, we have a great deal of empathy that comes with us into our work. And unfortunately, I think along with that is flaws in the armor, the fact that you feel for your clients the way that they feel for themselves often. And it can be challenging, but at the same time, the way that I deal with those situations is by also balancing that out with the good that you do, right? So the fact that you may be working with individuals who are in crisis, who are in these situations that are incredibly challenging for them, it's okay to feel for them and to understand where they're coming from and to feel badly for the crises that they may be experiencing, but at the same time to acknowledge the fact that you as a professional are helping them navigate those incredibly challenging situations, can take what could be a very challenging situation for you to be in and make it one that's empowering. So you take the good, you take the bad, you take them both, and there you have the profession of psychology.
Nice 80s callback to the facts of life. So I'm sure other folks on the panel have other wonderful advice about this as well, since everybody works with people who are going through challenging things and through pain and suffering.
I think it's important to know when you might need to seek some help yourself. I think a lot of times sometimes people might assume if we're in this field that we have it all figured out, and we don't, right? And sometimes we have to be very self-aware and knowing, like, okay, here's a situation that I'm, maybe this is a person or a kid that I'm working with, and I'm having a really difficult time letting that go, so maybe I need to seek help for myself to talk it out and, be able to get myself the coping skills to kind of work through whatever that situation is. I think it's also important to have colleagues that you can kind of talk about cases and things, through to kind of help you vent and feel better. And also, it sounds so, cliche, self-care. Like you really have to work to take care of yourself a lot of times. Like one thing I do is once a month, I have like a say no day where I make no plans with anyone. And so my friends and my family know, don't ask me to do anything because the answer is no. And I wake up and I just kind of see where the day takes me. And I think for me, like I need that for my own mental health and my own self-care to kind of get my separation. So it's just kind of, figuring out what works for you and don't be afraid to get help if you need it, if you feel like that's a struggle.
I just wanted to say, I know I've spoken a lot, so I'll make it brief, but I would say I love that. And I recommend that to my students in our master's program. It's not required, but I highly recommend that if they haven't ever been through therapy before, that they see a therapist, especially those first field experiences. Practicum and internship can be very overwhelming. You're hearing stories that, you never thought you'd hear before. And so I think having the humility to say, hey, I don't know it all, and I actually do need help, and this is affecting me. And I kind of think if you're a good clinician, things are going to affect you. Some things are going to get in because you're empathizing and things like that. So, yeah, support networks, seeking your own therapy, and then also recognizing the limits of what you can do. I try to teach my students that as well. Like we see our clients an hour a week, and then they go live however many other hours there are in a week, the rest of their lives. And so, although we can make really big change in people's lives and help them through things, we're also limited. And so not feeling like you have to be the superhero all the time for everybody, I think is important.
Definitely, this is definitely one where there's no perfect answer, I think. It's something I always check in, when I've supervised doctoral students or interns or other psychologists, especially working in like a forensic field. I think there's a lot of ways where it's probably the most maligned population you could work with, people that have committed sex offenses and these things. On top of that, it can be just extremely difficult to work with. A lot of that pathology is going to find its way out, eke its way out through, these different processes, and people are going to have all kinds of reactions. So I think about things like trauma groups for people that have caused trauma in other people, but kind of the impetus there is some trauma of their own as well. So in order to manage that risk, you want to help people process and address that, but it's really heavy material. And I think having like self-care probably the most important thing. Some of the most helpful advice I got is we're not doing something in this profession where you have something tangible to look at the end every day. You don't have you're not building a chair or lacquering wood or something. So find something where you can do that. So I think he was actually very into lacquering wood. So that's probably why he got there. But I think those kind of tips are super helpful too, just to kind of parse that apart a bit as well. Because at the end, like people are pointing out too, that there isn't like it's up and down at times, and you're working sometimes with people that are not having, sometimes it's the worst part of their life. So being able to realistically talk to yourself about that and manage self-care too, all helpful stuff from my opinion.
I would just add to that two things. One is when I've supervised new professionals, it is really overwhelming in the beginning to hold all that stuff from other people. And so I think it's also good to know that it does get better, that as you get more experience, you can kind of put it in its proper place and go on about your life, and it's not consuming you like after you stop working every night. That being said, it's always there. And right now I just have a general family therapy practice. And so it's so amazing to me how many times, I mean, they always say you get the clients you need. It says that people, you get the clients who are working on things that maybe you just are one step ahead of them in your own life. Sometimes, like, I just before this, I saw this man who's dealing with both his mom and his dad are one has Parkinson's, the other one has dementia. They're caving at the same time, and I saw my mom through with dementia until she passed, and so like this really difficult time in my life is coming up now in service of somebody else, and I totally get how spent this man is. So it's not like I have to literally go back and relive what happened with my mom, but I have some of the things that I went through can be applied, and it just happens over and over and over again. About how many times I would say to myself, "Wow, now I know why I went through that, so that I can have empathy around this particular thing," and how interconnected it all is. It's really, we're not going spiritual, but there is spiritual pieces to this that if you're willing to look. And again, I don't have any particular spiritual philosophy in mind, but if you're willing to look, and the whole question about why are you here, and what is your purpose, and what gives your life meaning, most therapists I know would say that helping other people and their practice gives their life meaning, among other things. But it's definitely a powerful experience to be a clinical person and to deal with people in fields where people are in pain and suffering.
So much great advice that, yeah, just resonates with my experience as well. It was Michael, and you're talking about like the woodworking. When I had the most patients in my private practice, I was sewing every night because I would want to go home and be like, okay, I can sew a right angle, and if I don't get it right, I can take the stitches out and try it again, and I get a finished product, and I can make it look how I want it to look, and which is so different from working with people where they do what they do and you try your best, but you can't get it to be exactly how you want it to be. So it was, yeah, the self-care and the hobbies and the all of that is just so important. Okay, another great question from Nick, and I think we're going to need different people to talk about this from their perspective of their different fields, because his question is there a test to get certified to practice therapy counseling, and what is it like? And there are various tests depending on your field. So if everyone could kind of speak briefly about that piece of it, like the licensure piece and what that entails in your particular field, that would be great.
In applied behavior analysis, you are able to practice at the master's level, and the course or the certifying exam that you take is the board certification exam for behavior analysts, right? It's a national level exam, so once you become a board certified behavior analyst, it's recognized nationally, and you are in most states able to practice with that certification. But in states like New York, there are daughter licensure exams that you may need to take. In the state of New York, recently there has been some changes to the laws such that if after you pass your BCBA exam, it kind of counts for your license as a behavior analyst in the state of New York. You just need to submit a couple of pieces of paperwork to the Office of Professions, and then you become licensed.
For mental health counseling, you also get licensed at the master's level. And so once you complete your master's degree, which includes 700 hours of field work wrapped into your master's practicum and internship, then you graduate, and then you are eligible to take the National Clinical Mental Health Counselor exam in New York. Some other states, it's a different exam. This one's harder, I'll be honest, because it's New York. But you take that exam, and then you complete 3,000 hours of work under what's called a limited permit. So during that time, you're working under the supervision of a licensed mental health professional. And then once you complete that 3,000 hours, which usually takes most people 1.5 to 2 years, once you complete that and pass the exam, then you're a licensed mental health counselor and you're free to practice wherever you would like. So.
I would just say marriage and family therapy the track is very similar to mental health counselor. So I don't have to repeat all that, but I would just say you have to go and look and see what what the experience requirements are and what the testing requirements are. And you'll see the patterns repeated, but some professions are different than others. So you have to look at your individual one. And also it does matter what state you're in. Like with marriage and family therapists, sometimes you have to, if you want to practice in several states, if you want to do online therapy in different states, sometimes you have to check and make sure that you might have to take a test for each state or that you want to practice in.
Social work is very similar. After the master's level, you will go ahead and you will be able to take the licensed master social worker exam from there. But same thing you have to do, a certain amount of hours that are a part of your internship and, your graduate school program. Yeah, so pretty similar.
Pretty similar for clinical psychology. I think like the big thing maybe I didn't understand when I was an undergrad was that you're not just like thrown into it. There's various levels of supervision along the way. So you're doing clinical work under the supervision of someone that does have a license. For clinical psychology, it's about 4 to 5 years for most programs, as far as I know, to do the school part. Then you have a year-long internship, and then you have a year of practice, and then you can take the big scary test, which is the EPPP for clinical psychology. Not that scary though.
I can't even remember what EPPP stands for, but I remember taking it.
Professional practice of psychology.
Oh, there we go. Exam for, okay, yep. And
And Dr. Warren Farrisee, you also got board certified recently. So do you want to say
I did, yeah. So for neuropsychology, so neuropsychologist is actually not a protected title, so which is a whole nother ball of wax I won't get into. But basically you get, so I took the EPPP and then for neuropsych, it's highly recommended that you do a 2-year postdoctoral fellowship, during which point you will get all those supervised hours and the additional clinical experience within neuropsychology. Then there's an additional level if you want. It's strongly recommended, but not required to become a board certified neuropsychologist. And that process is completed over, it can take up to 7 years. There's a written exam. You submit some of your reports that then get accepted if they're acceptable. And then there's an oral exam as well. So that's a whole nother process. I just completed that 2021. So that was I was very happy to have that monkey off my back finally, but it's not required.
That's definitely something to think about later. You guys don't have to worry about that yet. That's kind of a later
way down the road.
Yeah. Okay, and then wonderful. So Erica has a question. I think this is more for the folks that work with children and students. So probably Adriana. How do you build rapport and trust with students to get accurate information about a student's needs?
Actually, can I just say, I think it's a great question, but I feel like everyone could answer that. I mean,
Okay.
if you just
Yeah, that's true. It does
do
apply for
the word client for a
True.
student. Yeah, I'm sure it'd be interesting to hear about how all of you go about building rapport.
Do you want to start, Adriana, though?
Yes. So my style is, especially working in the school system, I try to know all the kids because I feel like when you build a relationship with the kids, when things are good, they're more likely to come to you when things are bad. So that's why we do a lot of, class-wide push-ins. In the mornings, I do my best to like stay around the doors when the kids come in, or when they come off the bus or when they're leaving, popping into lunch periods, just so they get familiar. Kids are so curious, so they'll be like, "Hey, who are you?" And they'll kind of come up to you and ask you questions. And so I think just being around and being available, doing, popping into classes just to say hello sometimes, I think is the first step in kind of building those relationships, is that familiarity piece.
Could other folks talk about how you build rapport to gain trust? I would imagine, Michael, that would be challenging with your population, actually. So can you speak a little bit about that?
Yeah, absolutely. So yeah, most of the people I've worked with clinically, in like civil confinement settings or prisons, are mandated to participate in that treatment, or it's heavily implied, hey, it's probably really good for you to do this, but they don't necessarily want to be there. So I think building rapport is a really important piece. There are times I think where sometimes people can walk in and kind of say, hey, here's what we're going to do, here's what it's going to look like, and that's really going to be okay. Rapport can still be built. There could be a lot of resistance with folks that are mandated for treatment or in settings where they're not super thrilled about it. So I think a lot of it is just kind of an understanding, like, hey, how do we build a common goal together? What can we get out of this? There's something called motivational interviewing, which is kind of ask a bunch of open-ended questions and directing and pulling from what someone puts out there. That's very helpful in developing that kind of rapport. I think just having some understanding too, like I'm working with people that are coming from all kinds of different experiences. I also probably look like a lot of the people that could have caused harm to them in the past in some way, shape, or form. Or, institutions are not perfect. And I think understanding that it's okay for them not to trust you from the get-go, completely reasonable. And you kind of work from there too. I find that's kind of been the most helpful thing for building those relationships.
In the field of applied behavior analysis, when you're working with children, of course, there are specific issues that you have to overcome. One of those being the development of a really good rapport with that child, because often, especially when you're working with populations who engage in challenging behavior, often those challenging behaviors occur because they help the child get their needs met. Sometimes, if those needs are escaping aversive situations like academic demands, to work on those problems, you have to work on those problems. And that can be a really aversive situation if you don't have appropriate rapport with the child. So the very first thing that we do is establish our clinic as a good, fun place to be, right? We play games, we let the child direct play, we engage, we encourage engagement from our early learners to ensure that they feel safe with us and that they are enjoying their time with us. But another part to that puzzle that we very rarely talk about is that we need to also build rapport with the families. Um, because what we're doing as therapists is modifying the environment in such a way that we're arranging more effective learning opportunities for those early learners. And what's the environment at home? It's the caregivers, right? So we need to take very thoughtful steps to engage the caregivers in that treatment process so that it's not simply us doing our business and then at the end we hand the child back to the family and say, there you go, right? We are pulling them into the treatment process, allowing them to have input on what we're doing therapeutically so that when it comes time for them to actually implement these treatment recommendations in the home or for teachers to implement these treatment recommendations in classroom settings, we've built that relationship, we've built that trust. They see the impact that those protocols can have on behavior. And through demonstrating that impact, we're able to modify their behavior as well.
Excellent. Thank you. Oh, yeah, go ahead, Suzanne.
I was just going to just tag along with in family therapy with children. I think I normally start out with questions that everybody in the family can answer. So I would want to build an environment where the kids think I'm not just talking to the adults and the kids aren't just sitting there. So I want to start out asking questions that everybody can answer just to build rapport, but also and then gradually get into things that have more meaning. But I think right in the beginning you have to set the stage for it. This is a place where kids can talk and where they're not going to be interrupted either. And so everybody gets a chance to talk in this room. And so sometimes parents want to talk for their kids, but this is so you have to kind of block that a little bit and let the kids have a chance to talk. Likewise, you have to remember that kids like to express themselves non-verbally, and parents usually like to talk. So sometimes you have to integrate in family therapy. You'd want to integrate maybe drawing or clay or movement and some things that maybe the adults aren't as comfortable with, but that the kids might be more comfortable with, and so that you get expression in all various forms.
Excellent. Lots of different ways to engage people, build trust. So another question from Elizabeth for Lauren Warren Pharisee. Can you talk about your experiences during your fellowship?
Sure. Yeah. So I had the opportunity to just work with a pretty wide variety of patients from different kinds of disorders, different cognitive issues. So a lot of differential diagnosis of dementia. So did this patient have Lewy body dementia or Alzheimer's disease? And it was full-time clinical. So just got to see a really wide variety of patients, got a lot of great clinical experiences, had great supervision, was able to be involved in a few research projects as well, looking at postoperative cognitive decline in patients who had general anesthesia, things like that. Yeah, so I don't know if there was anything more specific, but just a great kind of broad overview of lots of different patient populations and furthering my experiences in that regard.
So I have one, I think, closing question for you all, and that is, where do you see your particular field headed? Meaning, like, are there changes you've seen in your field, or where do you feel like it's going, given that these students are looking ahead and might enter the field and potentially be in it for 20 or 30 years?
I know I just talked, but I'll say my thing and then I'll stop talking. Neuropsychology is, I'd say we have two really huge I think there's a lot of growth. I think that it may look very different in 20 to 30 years, actually, for a few reasons. I think everyone, or maybe this is just sort of, I don't know, it seems like the medical field generally, there's questions about how AI is going to change our practice, how it's going to change our conceptualization, how it's going to change our day to day. And that's definitely true within neuropsychology. And then the other like really big way in which I feel like neuropsychology is shifting is that a lot of our normative data are based on like Midwestern white people in the US. And we are really struggling and working hard as a field to make neuropsychology more accessible and open, not only to other people in this country as the demographics change, but also to the world. So it's a really exciting time. It's sort of a scary time, but it's because I don't like change, but it's a very exciting time to be within neuropsychology. So those are the changes where I see the field going in the next 20 to 30 years. But there's always going to be people aging. There's always going to be people with brains. So I feel quite certain that we're going to need people to assess those brains.
This is a stumper, Deb. Very good question. Behavior analysis since the 1960s has been uh, I don't want to say insular in that we don't make inroads with other fields within psychology, but we have sort of marched to the beat of our own drum, so to speak. And recently, and continuing on into the future, there has been a strong push toward integration of behavior analysts within other healthcare fields. Including other subdisciplines within psychology. So cognitive behavioral therapy is a very, very potent and popular treatment methodology within psychology that incorporates components of not only behavioral psychology, but as also cognitive psychology, as the name implies. And that integration is going to be key for the long-term trajectory of behavior analysts outside of the field of developmental disabilities. We have such a prevalent role in the assessment and treatment of behavioral concerns in individuals with intellectual and developmental disabilities because behavior analytic methods tend to be really highly effective there. But with the broader application of behavior analysis, I look forward to seeing more integration of our methods in other popular treatment modalities.
I think as far as social work, I think the world needs more social workers. I think that, a few years ago in the school system, it was, one social worker per school, and sometimes they were even split time between two schools. And now with my district, we're trying to get two social workers per building because people just need help. But that's across the field, all ages, whether it's children or adults. I don't think I know a single social worker that works just one job. We're all doing like contracting work on the side or some private practice or just something like that because there's a lot of opportunity and just need within the social work field for sure.
I'll echo like I guess the ominous cloud of AI. I think scares a lot of people, but I think less so in this field. I imagine it'll be a long time or never, perhaps, before they stick ChatGPT in front of a hostile attorney and have it defend a report. However, I think there's like, a lot of things this field is going to grow and require. COVID probably showed a vulnerability there for the need of this field and will continue to. As far as like my area of practice in particular, I think there's a ton of cool research that has finally started to catch up in the field. A lot of cool statistical techniques. A lot of the time in the past, recidivism research was, does this predict that? And it was pretty limited in the scope. And we're getting a lot better idea now. One that like evil is not a very useful psychotherapeutic construct, and having an understanding of kind of the mechanisms underneath why people do things, it gives us a lot better picture of one, how to predict like future violence, and two, how to intervene also. So I think that will continue to grow. There's a lot of cool stat stuff coming out that is going to change, I think, how treatment is done in this area of the field and how assessment is done as well.
I can say for mental health counseling, I think one of the biggest things for our field has actually been telehealth, with the pandemic sort of accelerating telehealth. I think it's kind of exciting, that, I have clients all across the state. And so it really allows you to really hone in on a specialty if you're interested. Like my specialty is working with bisexual men, and I probably couldn't do that if I only did in-person practice. I couldn't have a full practice that way, but because I can, see people all over the state, I can. And then the other piece is we recently in New York State got diagnostic privilege, which there's a whole thing about that, too much to explain. But prior to this, in the laws, mental health counselors weren't technically able to diagnose mental health disorders, even though it's like what all our training is. So now we have that privilege. So if you're a graduate from the program after 2025, you can do that. So it opens up our ability to work in multiple different settings, multiple different insurance companies will reimburse us. Now we have no sort of nothing's holding us back, I guess, now from any of that. So that's the other most exciting thing.
Suzanne, do you have anything to add? I think everybody answered that one.
I mean, not too much different from the other counseling fields. I mean, except to say that I find that, like, as a relational person, online, I mean, seeing people online and for couples and families is better than nothing, but it's not as good as having people in the room. So, like, I have concerns about the training of the field, that it's if the training is just online training and the supervision is just online supervision, I have concerns about that. So I would just say to any of the students there, make sure you get a variety of training experiences, and some of it is with you in the room with people. Because if you don't get that while you're learning, it's just a whole different ballgame. Even like if I see couples, even if I've only seen them one time in the office, it's different. Like during COVID, I had such pain in my shoulders because I kept leaning forward, trying to get more data, trying to see more into the screen. And so it's better than nothing, but it's not the same as having people in the room. And so just get some extra experience with that, no matter what your program says. Even if you can do it all online, get in the room with people and have the experience of the energy in the room.
Excellent, excellent advice. Yeah, especially for looking at grad programs and what they offer. All right, well, it is 8 o'clock. So thank you so much to all of our panelists for joining us and sharing all of your collective wisdom. And thank you to the students for showing up and asking wonderful questions. And like we said, we're going to have the recording available on the CNYPA website, which I put in the chat, but it's cnypa.net. And have a wonderful evening. Thank you so much.
Thank you.
Thank you.